Hi, everyone. Welcome to this session. I'm just gonna wait probably a few seconds before we get started. I can see people are starting to trickle in. So I'll just begin with the introduction. So my name is Gurjot Basra, and I'm the Manager of Patient Programs, Research, and Advocacy at Lymphoma Canada. I'm so pleased to welcome you all to the first live session of the National Patient Conference. This educational session is titled Lymphoma 101 and the Importance of Knowing Your Subtype. For patients newly diagnosed, it can be confusing to navigate a cancer diagnosis and to prepare and set appropriate expectations for management of your lymphoma. This session will provide an overview of important information for lymphoma patients, including information regarding classification, staging, diagnosis, and treatment. This session will also cover why it's important to know your lymphoma subtype and how it relates to your care and treatment plan. So before we begin, there are a few things I'd like to bring to your attention. So this session is being recorded, and the recording will become available following the conference. You will receive an email when the recordings become available. At the end of this presentation, we will leave approximately 5 to 10 minutes for a Q&A session. To ask your questions, you can type them in the questions box, which is in the middle of the black toolbar at the bottom of the screen. We will try to answer as many questions as possible. So without further ado, today we have here Dr. David Scott, who is the Deputy Head at the Department of Lymphoid Cancer Research, is a Clinical Director at the Center for Lymphoid Cancer, and an Associate Professor at the Faculty of Medicine at the University of British Columbia. Dr. Scott leads a research lab that focuses on discovery and development of clinically relevant biomarkers to improve disease classification and patient care. So thank you so much, Dr. Scott, for joining us today, and you can get started as soon as you're ready.
Thank you very much for the kind introduction, and it's a real privilege to be speaking to everyone today about this interesting topic. I'm a hematologist originally from New Zealand, so thus the weird accent, and I spend 20% of my time looking after patients with lymphoma and 80% of my time doing research at BC Cancer. Here are my disclosures, and as I go through, probably the most important one is that I'm an inventor on patents describing using gene expression to identify different sorts of aggressive B-cell lymphomas, but I won't be talking much about these specific tests and assays today. The outline of the talk is I'm going to start off with a little bit of history, which I like to do to sort of frame things, but also it's important for how we divide up and classify lymphomas. I'm going to talk about quite a lot of biology to give you an idea of where lymphoma comes from and why it develops. I'm going to talk about classification, which is what types of lymphoma there are, and also how we diagnose them. I'm then going to go on and talk about how common is lymphoma, and then I'm going to give a brief overview about how lymphoma is treated. So this is going to be a talk that is broad brushstrokes. So it's like the Van Gogh on the right, rather than the pointillist style Seurat on the left. I'm going to make some very gross generalizations because this is a massive topic, and lymphoma is a very complex disease made up of lots of different types of diseases that are treated differently. So if I say something that doesn't jive with what you've been told by your care team, please ask questions at the end, or actually pose these questions to your care team, because I don't want to create confusion here, but I do want to give some broad principles that hopefully will make sense to you as a newly diagnosed patient or a family member. So I'm going to start off with a little bit of history, because lymphoma has got a very rich history that now dates back to the time of this man here, who was Thomas Hodgkin. He was a physician in London, and he presented on the very first description of what we now call Hodgkin lymphoma. So he gathered together a bunch of cases that we're now in the medical field called a case series. What you did back then was somebody stood up and read what you talked about, and in this case it was presented on January the 10th and 24th of 1832, and he had seen a series of cases of patients who had large, what they called absorbent glands, which are lymph nodes, and spleen, and they had night sweats and they had weight loss, and they ranged from children to people at that time called elderly, which was really people in their 40s and 50s. And this was largely forgotten. And then about 20 or 30 years later, some researchers in, I can't remember whether it's Oxford or Cambridge, I think it was Oxford, actually saw a similar series of cases, and they looked through and they said, oh, I know what we'll call it. It's actually been described before. We'll call it Hodgkin disease. And that's where this all began in terms of the first description of lymphoma. And for a long time, it was thought that this was actually tuberculosis, and that really he had just described a weird presentation of that particular infectious disease. But then in 1899, Dorothy Reed, who was a pathology resident, or the equivalent of a pathology resident in the US, and Carl Sternberg, who was in Germany in 1900, looked down the microscope and they saw these very distinctive, interesting cells called Hodgkin and Reed-Sternberg cells shown at the bottom here, which have these, what they call owl's eyes appearance here, which showed that this was a malignancy and not an infectious disease. And in fact, they've looked back on those cases from Thomas Hodgkin using modern pathology at the original cases, and about half of them were Hodgkin lymphoma, and about a few of them were tuberculosis, and in fact, some of them were T-cell lymphomas. So he largely had this correct. So what are lymphomas? Well, they belong to a class of cancers called the lymphoid neoplasms, and these are cancers that arise from B and T lymphocytes. And these are cells of your adaptive or learning immune system. And we split these up according to how they present, and I'll give you a little bit more information about that later, into three categories. We have the leukemias, which means white blood. So these are circulating cells. We have lymphomas, which really are lumps and bumps. And then we have plasma cell neoplasms, or myeloma, are the three categories. So I'm only going to talk about lymphoma today, and not about the leukemias or the myelomas. So I think to understand lymphoma, it's very useful to understand the underlying biology of these particular cells, to understand where lymphoma comes from, and the sort of mechanisms that lead to it, and how we then go on and classify it. And I'm going to focus today on B-cell lymphomas because we know a lot more about this particular biology, and these make up 90% of the patients that we see in the clinic. So the workhorse of our immune system is a cell called the plasma cell, and these cells produce antibodies, and that's the job of the B cells in our immune system. So the antibodies are produced by the plasma cells. There is one antibody per plasma cell. So each cell produces just one antibody. And the job of these antibodies is to recognize foreign proteins via a little portion on the end of these arms, which is called the variable region. And the variable region, you can think about it as the lock. And then you have the antigen, which is the protein, which is on a virus or on a tumor cell or other protein, and it fits in to the lock and is bound. And when it's bound, that marks that particular protein or that virus or cell for the immune system to come and destroy it. And that's how B cells contribute to our immune system. And when you think about vaccination, what we're doing is we're exposing the body to a particular antigen, in this case, a viral antigen, and that produces a lot of antibodies that can then or a lot of plasma cells and memory cells that can then very rapidly respond when they see that particular antigen, in this case, the actual virus or bacteria in the future. So our immune system must be able to produce antibodies that recognize a vast array of potential antigens. So we need millions of different locks in order to maintain our integrity and not to die from viral infections and bacterial infections. So I'm going to walk you through this development scheme, starting from cells in our bone marrow or blood factory, right through to the workhorse, which is the plasma cell, the antibody factory. So we start off with very early cells in our blood factory. These are start off with things called hematopoietic stem cells, and they're cells that are able to divide endlessly, and that's where all of our blood cells originate from. And the B cells go through developmental stages from things called progenitor B cells through to immature B cells before exiting the bone marrow into our bloodstream. And it's in the bone marrow that we get the first process that produces all of these millions of different locks. And in order to make different variable regions, we have things called immunoglobulin genes, and they're made up of little short sections called V, D, and J sections. And an enzyme comes along and it actually deliberately cuts up pieces of DNA out of this region and fuses things back together to produce a unique VDJ segment, which is the thing that actually produces this specific lock. So this process develops millions of different locks, and it also involves very deliberately making breaks in our DNA or genetic code. These cells then exit the bone marrow and go into the bloodstream, and at some point they encounter their protein or antigen. And they do this largely within lymph nodes, which are the sampling centers or sampling stations of the body. So if you have a piece of skin, you'll have lymph drainage from this and little lymphatic ducts, and that will go to a lymph node in, for example, your neck. And if you get infection in that piece of skin, what happens is that those proteins are processed and they drain back to the lymph node that then becomes often quite large, hot, and inflamed. And that's the immune reaction producing lots and lots of B cells to then produce the antibodies that then deal with that particular infection. So this is the distribution in the neck. The lymph nodes are these little yellow nodes, or that's why they're called nodes, and they're linked by lymphatic drainage, which are these little tubes. And you can see this is now the bowel, and for some reason, the fantastic artists who actually produced this, whose name was Netta, has decided this time to make the lymph nodes dark black or gray, and you can see this network of lymph nodes around the bowel, and also down the vessels that are in the groin and abdomen. So the germinal center is a structure within these lymph nodes, which is the B cell training camp. And in fact, these little centers called germinal centers contain the most highly dividing cells in the body. So they're rapidly dividing and expanding to produce more cells that can produce these antibodies to deal with the particular infection or invasion. And these cells go in here, they turn into cells called centroblasts. They are very, very actively dividing. And then they become centrocytes, and that's where they're selected to say, do you have a really great lock? Or in fact, do you have a pretty poor lock? And those that have a great lock go on to be memory B cells or plasma cells, and those that have poor locks go on and die. And it's during this time, and in fact, it's really the centroblasts, that we get more fine tuning of the lock to make sure that it's fantastic at binding that key. So that's the fine tuning of the lock. And that's done by another enzyme called AID, and it is deliberately going about creating mutations. So it deliberately mutates the variable region to produce an even better lock. So in the bone marrow, we had an enzyme that deliberately cuts up DNA. And in the germinal center, we have in the lymph nodes, we have an enzyme that deliberately mutates DNA. And this is all occurring in some of the most highly dividing, proliferating cells that we have in our body. So you can understand that this might be, although a fantastic process, might also be quite a dangerous process for the body. And then we go on and the cells that come out are plasma cells, which do the job of producing antibodies, and memory cells, which are sitting there having seen this antigen, and when they see it again, they go back into these training camps and produce lots and lots of plasma cells, and that's how vaccinations work. And when we look at the B-cell cancers, we can actually think about how they fit in to these different developmental stages. So those cancers that look like things that were early in the development, they're actually our B-cell acute lymphoblastic leukemias. Things that sort of fit in the middle here in the development, they're our B-cell lymphomas, but also CLL, chronic lymphocytic leukemia, and small lymphocytic lymphoma. And then those things that look like plasma cells are the myelomas and lymphoplasmacytic lymphoma, which is another name for Waldenstrom's macroglobulinemia. And we see a very similar type paradigm for T-cell lymphomas as well. So what causes lymphoma? Well, the normal immune system is in a very fine balance and check, because you want to produce antibodies when you need them, but you want to be able to turn off this process when it's done. So in the lymph node, we have massive cell division to ramp up these cells. And then we have a balance of things going on and being plasma cells or undergoing cell death or apoptosis, particularly if they're not producing very good antibodies. So it's a balance between cell division and death that is maintaining normal immunity. And in lymphoma, we have three things. First of all, we have uncontrolled growth, and those are through mutations of our genetic code that allow continuous cell division without listening to signals to say slow down or stop. We have blocks that prevent these cells from dying, and BCL2 is a really important protein in that. And then we also have blockade to these cells becoming plasma cells. So if we didn't have that blockade, what we'd end up with from this process is lots and lots of plasma cells. That's myeloma. But in lymphoma, we have blockade from becoming those mature cells. So lots of people ask me, they say, well, doctor, why did I get this lymphoma? And also that leads into the question of how can I prevent it coming back once I've had treatment? And it's a difficult answer, because the answer is that this development of lymphoma in many cases, or in fact, most cases, is a result of having a very clever immune system. So back 1,000 years ago, or even 100 years ago, the thing that threatened human life the most was bacterial and viral infections. So it was really great to have a clever immune system. But now that people are living longer and we have antibiotics and vaccinations and things like that, we start to see the effects of having this very clever immune system. And so what happens is these mutations that occur, they are largely due to misfiring of the mechanisms that produce and fine-tune the antibody locks. So it's breaks in our DNA caused by that enzyme in the bone marrow, and it's mutations that are caused by that enzyme, which is supposed to mutate the lock that is in the germinal center. Now, that's not all the story, it's most of the story, but we also have other contributors, particularly in select lymphomas. So in some cases, a contributor is chronic exposure to the antigens or keys. And the classic example of this is a bacteria called H. pylori that lives in the stomach and can be associated with a lymphoma called Molt lymphoma. And we know that if we eradicate that chronic exposure that's stimulating the immune system by getting rid of this bacteria, that in some cases that lymphoma melts away all by itself and doesn't require further treatment. We also know that people who have autoimmune diseases like rheumatoid arthritis and Sjogren's also have a higher rate of having lymphoma because of that chronic exposure that the immune system is having to particular antigens. We know that there are certain viruses that contribute. The most well-known of these is Epstein-Barr virus, but that's complicated because 90% of us have been exposed and have this virus in our body, and yet we don't get lymphoma. And so we think that it's an interaction between the virus and our immune system that leads to that. And then we have exposures. We think that this is a very small but important contributor, but it's hard to work out. There's no smoking gun as there is in things like lung cancer. And then there's a very small contribution, we think, from inheritable susceptibility. But in most cases, there is no family history. And we haven't found specific genes that give rise to a greater chance of you handing on lymphoma to your family member. So in most cases, that's not at all a factor, we think. So now I'm going to go on to classification, which is what types of lymphoma are there and how do we diagnose them? So why do we bother with classification? Well, it's important because if you're diagnosed in Toronto or you're diagnosed in Vancouver or Calgary or Delhi or Auckland, New Zealand, which is where I'm from, we want the same diagnosis for all of those people, and that it's not where you come from that then contributes to what sort of diagnosis you have. And it's important because we want to be able to give the right treatment at the right time with the expected results. And one of the most important things we can do as doctors for our patients is to get the diagnosis right, because it has a massive impact on how we manage the disease going forward. And finally, it also allows studies to identify causes and better treatments. And this classification is being updated every 5 or 10 years. It's in a particular book, which is called the WHO classification, or the Blue Book. And this Blue Book sits on almost every pathologist's desk around the world. And this is the scary version. And it's deliberately small so that you can't read it. But there are dozens of lymphomas, 50, 60, 70 sorts of lymphoma that we recognize as entities in this classification, and they are evolving over time. So our slate of lymphomas that we have today is subtly different from what it was 5 years ago, and quite different to what it was 20 or 30 years ago as our tools and our knowledge advance. So how do we diagnose lymphoma? Well, it starts off with a biopsy, and I've shown something which is increasingly rare today, which is what we call an excisional biopsy. So that's a lymph node. We then place the biopsy into some formalin where it's fixed, and then we put it into a block of wax, a paraffin block, and that allows us to do very, very fine cuts of the tissue to look down the microscope. We also take off, if it's available, a little bit of tissue, what we call fresh tissue studies like flow cytometry and molecular studies that I'll go through in a sec. Now, I'm saying that this is increasingly rare because more and more we're using things called core needle biopsies. Those are typically performed by a radiologist where they use imaging to sort out where the lesion is, and then they use a moderately fine needle to take little cores of tissue that we can look down the microscope on, and that will also undergo this process. As pathologists, we much prefer what's shown here, but the reality is that core needle biopsies can sometimes be done more rapidly and sometimes are the only safe way of getting tissue. So how do we arrive at a diagnosis? Well, the one thing that the pathologists will do first is to look down the microscope and look at what we call morphology. So what do the cells look like? In this case, they look like sheets of large cells. And also, how are they arranged compared to the other structures that are in that piece of tissue? So that's morphology. They'll then also look at what's called phenotype, which is what sort of proteins are being produced by the cell, either within the cell or on the outside of the cell. They'll also do molecular studies, and we do quite a lot of looking for breaks in DNA. We use something called fluorescent in situ hybridization, or FISH, and we can also do tests to see whether in fact this is a cancer or not a cancer, and that's called clonality testing. And then obviously I made this slide a couple of years ago because I said that gene expression profiling and DNA sequencing are research, but now they're making their way into routine practice. So in mantle cell lymphoma and CLL, we're looking in some centers for mutations in genes like TP53. In CLL, we're looking to see the mutational status of that variable region I told you about, so IGHV testing, and that can tell us sometimes what sort of treatment we're going to use. And just in the last week in British Columbia, we've started to use a gene expression profiling assay on our aggressive B-cell lymphomas to help differentiate one type from another. So that I showed you the scary version. But there's also a simple version which helps clinicians and I think patients understand their disease a little bit better, although we still have to understand the complexity that actually sits behind the system. So the simple version is that lymphoma is made up of Hodgkin lymphoma and non-Hodgkin lymphoma. This is purely a historic perspective because we've known about Hodgkin lymphoma for almost 200 years. And therefore everything else was called non-Hodgkin lymphoma. And I don't think we'd build it this way if we built the system again today. And then non-Hodgkin lymphoma is broken up into B and T cell non-Hodgkin, saying that the cell of origin that it came from was either a B cell or a T cell. And if we look at this, 80% are B cell non-Hodgkin, 10% are T cell, and 10% are Hodgkin. So it's important to know your diagnosis because it tells you how we expect the lymphoma to behave, if it's left treated or untreated, but it also has significant bearing on how you're treated and what the intention is when the treatment is given. And all of this requires a good tissue biopsy. So occasionally you'll have had a fine needle aspirate, which is where they suck out some cells from a piece of tissue from your family doctor. That will then sometimes lead to a core needle biopsy, and occasionally that will then lead to an excisional biopsy because we're still not sure. So we need a good amount of tissue to make sure that we've got that diagnosis right because it's just so important. So how common is lymphoma? Well, this is the latest data from the Canadian Cancer Society, and the arrow here is non-Hodgkin lymphoma. If we add in Hodgkin lymphoma on top, we're more in the range of this bladder, thyroid, and melanoma type range. So typically lymphoma sits somewhere between the 4th and the 5th most common cancer in both men and women, because in women, breast cancer is the most common, and in men, it's prostate cancer. So you can see that it's not the most common, but it's still quite common, with somewhere around 10,000 new cases a year diagnosed across Canada. And with the exception of Hodgkin lymphoma, which is we see a hump in the incidence that occurs in people between the ages of 10 and 30, and then this particular pattern, what we see is that lymphoma increases with age. And that happens because our body continues to produce these errors in our immune system, but also as we age, our ability to recognize tumor cells as foreign starts to also fade, and we start to get more tumors, full stop, including lymphoma. So what this means is that we have a cancer that's increasing with age, but also we have an aging population and we have population growth. So in Canada, what we're seeing is the absolute number of new lymphoid cancer patients is doubling approximately every 15 years. So how do we actually treat lymphoma? Well, I told you the simple version of classification, and here's the simple version of how we think about lymphoma. Again, very gross, broad generalizations, but we split it into indolent lymphomas, which can progress or sometimes are stable for years. They don't always need treatment. And the most common type of these is follicular lymphoma, which makes up about 20 to 30% of all diagnoses we see. Aggressive lymphomas progress over weeks to months. Typically, they need rapid treatment and cause problems if they're left alone. And the most common type is diffuse large B-cell lymphoma, which makes up 30 to 40% of the cases we see each year. And this is a gross generalization, but indolent lymphomas, while not always requiring treatment, generally, particularly when they're widespread, are considered incurable with our current treatments, whereas the aggressive lymphomas, although they produce sometimes many problems up front and require immediate treatment, are generally curable. So having established diagnosis, the next question clinicians ask is how extensive is the disease? And in almost all cases, we'll want a CT scan, looking at the neck, chest, abdomen, and pelvis. In aggressive lymphomas and some indolent lymphomas, ideally we'd want a PET scan, just because that gives us an idea of if a smaller lymph node is involved or if the bone marrow is involved, as is the case in this particular scan, where we have these dark areas which are the lymphoma, highlighting the marrow of these arm bones and the humerus here. And increasingly rarely, we're asking for bone marrow biopsies, and that's in select lymphomas and situations where we can't tell with confidence whether there is involvement of the bone marrow or not, based on the scans that we have, and that would change how we would treat the patient. We use a particular, what we call staging system in lymphoma, which is different from every other solid cancer out there. And this is called the Ann Arbor system. And it was largely developed to tell us whether we can or should use radiation therapy. In other words, is the lymphoma localized to an area where we could do that, or is it more extensive? So stage 1 disease is a single lymph node area. Stage 2 is a number of lymph node areas. Stage 3 is where you have involvement above and below the diaphragm. And stage 4 is involvement or widespread involvement of an organ outside of the lymphoid system. So I've shown little spots here in the lung, but it could be involvement of the liver or the bone marrow, for example. So again, we have a simplified version of this, and this is slightly and subtly different across Canada and particularly across the world. But in British Columbia, we talk about limited stage, which is stage 1 or 2. So it's on one side of the diaphragm. You're not allowed B symptoms, which are things like night sweats, weight loss, or unexplained fevers. And the mass can't be really large. And that's also variable across which center you're in. But in our center, it's 10 centimeters. An advanced stage is everything else. Again, I have to say, broad generalizations, but this is how we think about the treatment approach. So if you have an indolent lymphoma and it's limited stage, we can think about curative intent radiotherapy. But if it's advanced stage, we're trying to avoid symptoms and we try and knock back the cancer as much as possible. And although this is called palliative intent, often we don't need to treat the patient again for many, many years. And in some cases, we never need to treat the patient again to prevent symptoms. With aggressive lymphoma in limited stage, we can shorten the course of chemotherapy, sometimes with radiotherapy also being used. And if it's advanced stage, we're still looking at curative intent, but most of the heavy lifting is done by systemic therapy. So what sort of systemic therapies do we have? We have three broad flavors. The one that's been around now for 50 plus years is chemotherapy. And this is what I've labeled the blunderbuss, in that it really goes and it kills all rapidly dividing cells to one level or another. And the examples here are CHOP, bendamustine, but also autologous stem cell transplant, because the way it works is it allows you to give higher doses of chemotherapy, and there's no other magic to it other than that. We then have targeted therapy, which is the molecular scalpel, and that specifically disrupts pathways within these lymphoma cells, which are important for proliferation and survival. And for these, it's particularly important to know your subtype, because these molecular scalpels are specific to certain types of lymphomas, and in some cases, lymphomas of specific types that have specific mutations. And examples are Bruton tyrosine kinase inhibitors, which are useful in CLL and mantle cell lymphoma, BCL2 inhibitors, which are also useful in those two diseases, and things called antibody drug conjugates, which are little antibodies that carry a chemotherapy payload and specifically take it to certain cells to kill them off. So it's kind of a combination between the molecular scalpel and the blunderbuss. And finally, and very excitingly, we have immunotherapy, where we have targeted destruction of the malignant cells, but also uncloaking them and making them visible to our immune system. So these are marking cells for destruction and making them visible. Examples which we've had now for over 20 years are the anti-CD20 antibodies, which are part of many regimens for B-cell cancers, PD-1 inhibitors, which have been really important for Hodgkin lymphoma. They are something that unmasks the cell and makes it visible to our immune system. And then we have the latest advances, which is CAR T-cell therapy and bispecific antibodies, which are ways of bringing your own T cells to recognize and attack the malignant cells to eradicate them from your body. So, wrapping things up, what is lymphoma? It's cancers that arise from our lymphocytes presenting as lumps and bumps. What are the causes? Well, in almost all cases, it's mutations. And these are mainly a consequence of having a very clever immune system, and in some cases, antigen stimulation and or viruses. Who gets lymphoma? Well, pretty much anyone. And the incidence generally, but not always, increases with age. How do we classify them? We have huge complexity, which luckily is something that our pathologists need to deal with. But we also have a simple system, which is Hodgkin versus non-Hodgkin and B-cell versus T-cell. And clinically, we think about them as being indolent or aggressive. How is it diagnosed? Well, it's diagnosed by a skilled pathologist looking at a really good biopsy. And then how is it treated? That depends on very much the type of lymphoma and how extensive it is. But the mainstay in most cases is systemic therapy, with radiation playing an important role in some cases. So thank you very much for your attention, and I would love to answer whatever questions people have if time allows.
Thank you, Dr. Scott, for that very informative presentation. Just a reminder to the audience, if you have any questions, be sure to leave it in the Q&A box below. It's located in the black toolbar at the bottom of your screen. So we do have a couple of questions that have come in. So we'll start off with, can you say something about mantle cell lymphoma and current treatment used?
Absolutely. And I think it's really important that I am going to, I can't speak specifically about a person's case because everyone's different. So I'm going to talk in generalizations, but a lot of factors feed into these discussions between patients and the care team, including goals of treatment and other patient factors. So mantle cell lymphoma is an unusual B-cell lymphoma in that it kind of sits between the two paradigms I've talked about, in that it sometimes is an aggressive lymphoma, but we generally think of it as incurable. So we think that the treatment that we give, although they can be very, very effective for our patients, actually don't cure the person long term. Treatments do differ across the country. So I'll talk about what we do in British Columbia. And at the moment, that depends on your age and comorbidities. So what other things are going on with your health? If you're a younger person, and we're talking below the age of 65 to 70, you'll get something like bendamustine and rituximab. In other centers, you'll get different regimens, and that will be followed by an autologous stem cell transplant, which is a way of giving you more intensive chemotherapy. And sometimes we'll follow that with rituximab treatments for up to 2 or 3 years. If you're an older person, we would be using the same regimen, but without the autologous stem cell transplant, because it's a little bit much for people who are older or have significant problems with their organs to cope with, and the benefit is not large enough to overcome that risk for people. We know that there are a number of really important molecular scalpels that work very well, and in many cases those have been used in second and third line treatment, and most recently in third line or fourth line treatment. In some centers we have access to CAR T-cell therapy as well. So we're really starting to use all of those different layers I spoke about: systemic therapy, molecular scalpel, but also the immunotherapies as well.
And we have another question. Somebody said, I had an enlarged lymph node in my neck and received a biopsy. They think it was a fine needle biopsy. Results indicated it was just a reactive lymph node. But a few months later, I was diagnosed with follicular lymphoma. How come the biopsy did not detect this?
Yeah, I can't speak about the specifics, but I can tell you that fine needle aspirates are just sucking out a little sample of cells. And sometimes it is very hard to tell the difference between a reactive process and a malignant process like follicular lymphoma, particularly follicular lymphoma. And that's why almost always a fine needle aspirate is not going to be sufficient to make that diagnosis. So what often happens with family doctors is they're seeing lots of enlarged lymph nodes for all sorts of reasons. And in almost all cases, it's going to be because of a virus or a bacteria. So typically, the family doctor will want to make sure that the lymph node is sticking around for a period of time or growing before they'll go on and do further investigations, just because lymphoma is rare and infections are common, and biopsies can cause problems with complications from that.
Next we have, is radiotherapy the same as radiation?
Yes, although radiotherapy is using it in a very targeted fashion, whereas radiation is obviously a much broader term. But yes, I think most of us use those terms interchangeably when we're thinking about treatment.
Any risk if we take watch and wait for follicular lymphoma grade 1 to 2?
So in patients who are asymptomatic, in other words, they don't have symptoms from the follicular lymphoma, and they don't have specific features that tell us that they're going to run into problems with symptoms or problems with organs in the near future, I think that watch and wait is a very, very reasonable strategy and is the most common strategy that's used worldwide. We know that there's no difference in terms of how long somebody survives depending on how rapidly that follicular lymphoma is treated. So there's really no major advantage in racing in and giving any form of therapy early. In some centers, they would offer rituximab single therapy, although that obviously has the risk of that particular treatment, but it also has the issue that it can or almost certainly will mean that you won't respond to vaccinations. So in the COVID-19 pandemic, fewer patients were receiving rituximab, but that's a discussion between the patient and the doctor and the care team in terms of thinking about what's best in that situation.
And then does brentuximab work for ALCL on the brain?
That's a question for Kerry Savage in the next session, because I'm sorry, I don't know the answer to that.
Fair enough. Can you differentiate between MCL and CLL?
You certainly can. So it can be a complicated pathology question, but they can be readily split apart. They're very, very different diseases in terms of how they present and how we treat them. So in mantle cell lymphoma, we do observe some patients, but it's uncommon. Maybe 10 to 20% of patients can be observed, whereas most require treatment at the time they turn up, which is different from CLL, where many people can be observed for years without further treatment. And the way we treat them does have some similarities, and we do in some cases use very similar treatments, but they tend to be different in terms of long-term outcomes. So they're quite different diseases, but related. Yep.
And where are we in using blood samples and DNA for diagnosis?
Yeah, that's an awesome question. So at this time, we still need, in most cases, a piece of tissue, but we are starting to develop tests called circulating tumor DNA or cell-free DNA, where we're doing genetic testing on that. And that can be useful in terms of diagnosing or helping diagnose certain malignancies. That's not widely used. The other thing is it's very, very difficult to tell apart lymphomas based on this, and a piece of tissue is much better for that. So you can have the same mutations in a follicular lymphoma and a diffuse large B-cell lymphoma, but they'll be treated very differently, and it means very different things for the patient. So we're getting there, and I'm not sure that they'll ever fully replace having a good diagnostic piece of tissue, but they can be very useful in terms of monitoring patients and seeing how well they're responding to treatment.
Thank you, Dr. David Scott, for answering those questions. That's all the time we have for this session, but if your questions were not answered, fear not, we do have a lot of Q&A sessions that are coming up. So stay tuned for the subtype sessions that will start in the next few minutes. Thank you, everyone, and I'll see you in the next session.
Thank you. Bye-bye.